Hello, my name is Dr. Guido-Sanz, and welcome to the Gastrointestinal Healthcare Problem series. Today, we're going to be talking about gastrointestinal mucosal injuries, specifically upper gastrointestinal bleed and gastrointestinal bleed. So, we're going to start with this first part of the series on GI mucosal injuries dedicated to upper GI bleed. Upper GI bleed is a common indication for admission. Out of the 300,000 admissions a year, upper GI represents 75% of the cases. Um, Mortality is associated with a 10%, and aging and comorbidities contribute to this mortality rate. A decrease length of stay over the past 10 years has been attributed to quicker endoscopic procedures within 24 hours and also 20 to 35% endoscopy with hemostasis therapy. The incidence for UGI hospital admission is one of 100 over 100,000. Men are twice more frequently affected than women. The risk increases with age, and patients rarely die from blood loss. Death is usually due to the compensation of comorbidities. There's mortality also affected if less than 60 with absence of malignancy or organ failure in less than 1%. So what are the UGI bleeding causes? UGI bleeding causes can be clustered by the origin or etiology uh, or cause. They can be caused by either mucosal issues like erosive or ulcerative conditions, by vascular conditions, by portal hypertension, tumors, traumatic, and other. The mucosal or erosive ulcerative causes of UGI bleeding include peptic ulcer disease, which is the most common in this category, stress-related mucosal disease, Zollinger-Ellison, and esophagitis. Vascular causes can be attributed to many syndromes like the Osler-Weber-Rendu syndrome, and also idiopathic angiomas, the blue rubber bleb nevus syndrome, radiation-induced telangiectasia, and so on. Portal hypertension causes includes, and very frequently in cirrhotic patients, esophageal varices, gastric varices, and portal hypertensive gastropathy. As far as tumor cause, they can be either benign or malignant. And amongst the benign tumors, you find the leiomyoma, polyps, and lipomas. Traumatic causes, Mallory Weiss tear. These are tears caused by repeated retching and vomiting that by increasing the intragastric pressure really make patients predisposed to esophageal varices and the rupture of these varices. So, but the primary cause is like those tears that are from repeated retching and vomiting. You see that also frequently in patients with anorexia and bulimia, that they self-induce very frequent vomiting episodes. And other causes, we find hemobilia and hemosuccus pancreaticus. I want to talk about a little bit about hemobilia. Hemobilia is upper gastrointestinal tract bleeding that originates from within the biliary tract and has become widely recognized due to an increase of clinical awareness of the disorder and also to improvement in diagnostic techniques. In addition, the growing use of percutaneous liver puncture for the diagnosis and therapy for hepatobiliary diseases and the increased incidence of both blunt and penetrating hepatic trauma have contributed to a rising incidence of hemobilia. We review the history, pathophysiology, and current approaches to the diagnosis and treatment of this disease. And we also see the Hemosuchus pancreaticus, also known as pseudo-hematobilia, or the Wurstson-Garrich, which is a rare cause of hemorrhage in the gastrointestinal tract and is caused by a bleeding source in the pancreas, the pancreatic duct, or structures adjacent to the pancreas, such as the splenic artery, that bleeding to the pancreatic duct, which is connected with the bowel at the duodenum, which is the first part of the small intestine. So hemobilia and Hemosuchus pancreaticus are entities on itself that are also causes, of upper gastrointestinal bleed. Speaking of peptic ulcer disease, 50% of the cases, represent the etiology for mucosal, either erosive or ulcerative causes for upper GI bleed. There are four major risk factors for peptic ulcer disease. The use of NSAIDs increase the Helicobacter pylori infection, present stress, and gastric acid. Anything that affect the aligning of the gastrointestinal tract can, and obviously the mucosa, can predispose to upper GI bleed. Ulcers are usually more frequent found in the duodenal than over gastric. And recent data shows that non-specific mucosal abnormalities up to like 42% are more common than the peptic ulcer disease itself, which is associated with a 21% in comparison. So here we have some endoscopic views of peripheral ulcer disease. On A, you have a gastric ulcer before, and B, after endoscopic intervention with gold probe cautery. So a lot of these endoscopic procedures are only not being done for diagnostic purposes, but also for therapeutic purposes, like cauterization of the injuries, and also ligation in the case of esophageal varices. Bleeding peptic ulcer. This shows an abnormal endoscopic view of the duodenum, showing a large erosion where the arrow is pointing, that is filled with a large blood clot. That's the arrowhead. Can you see that? This finding is typical of a bleeding ulcer, and sometimes when the GI physician is performing the endoscopy, those clots, the evacuation of those clots seem to be a little bit tricky, because it is uncertain whether the bleed originates from, like what they say, a pumper, like a small artery, and they have to be ready for cauterization to prevent more severe bleeding, because the clot serves as a hemostatic mechanical agent in those instances. Here we see a picture of what severe esophagitis is. You see the erosion all along the walls of the esophagus, depicted by the dark spots on the lumen of the esophagus. And this one shows hemorrhagic gastritis. See all that angry mucosa with large confluent areas of subepithelial hemorrhage. And you can see also there's a part of this lies in the lower right corner, the pylorus, and you see that that gastritis extends beyond the gastric area into the small, a little bit into the beginning of the small intestine or duodenum. But that's at the pylorus level. So vascular GI bleed. Mallory-Weiss tears represent 5 to 15%. This Mallory Weiss is a syndrome that is characterized by upper gastrointestinal bleeding, secondary to longitudinal mucosal lacerations, also known as Mallory Weiss tears. You need to remember this. At the gastroesophageal junction or gastric cardia. The original description was done by Mallory and Weiss in 1929 and involved patients with persistent retching and vomiting following an alcoholic binge. So anorectic alcoholics are very prone to having this um, entity. However, Mallory-Weiss syndrome may occur after any event that provokes any sudden rise in the intragastric pressure or gastric prolapse into the esophagus, and that includes antecedent transesophageal echocardiography. Mallory-Weiss tears account for an estimated 5 to 15% of cases of upper GI bleed. Although the age range varies, and varies widely. Affected individuals are generally in the middle age, between 40s and 50s, and men are reportedly have a higher incidence than women by a ratio of 2 to 4 to 1. So again, hemorrhagic cause of erosive or erosive gastropathy, very highly associated with the use of NSAIDs, alcohol, erosive esophagitis, and mild bleeds, but not massive. Sorry, here we see a Mallory Weiss tear result from prolonged and forced vomiting, coughing, or convulsions. Typically, the mucous membrane at the junction of the esophagus and the stomach develops lacerations which bleed. And they're very evident, these bleed by bright red blood in the vomitus or bloody stools. It may occur also as a result of excessive alcohol ingestion. And this is a very acute condition which usually resolves within 10 days without special treatment. Esophageal varices also is a cause for upper GI bleed, especially in cirrhotic patients and patients with acute liver failure or chronic liver failure. It's as a consequence of systemic or segmental portal hypertension. And the patients can be treated with propanolol. I believe Lopressor is not the brand name for propanolol. The brand name for propanolol is Inderal. So we need to correct that information. Massive bleeding is very closely related to liver disease in cirrhotic patients, and they go under some procedures like TIPS to try to control the bleed from this rupture of esophageal gastric varices. And obviously transplantation improves the prognosis because it takes care of the cause of the generation of these varices. 50% with the compensated 50% of patients with the compensated cirrhosis develop upper GI bleed. Very high incidence. This let me go back to this slide. You see here a cross section of the esophagus, and you see the varices, and these patients are also, we have to be careful in under normal circumstances for hospitalizations of any other for any other reason when you're inserting NG tubes and even doing endoscopy studies, because those varices are very fragile and they can bleed profusely very, very easily. Here you have a picture that depicts the whole relationship with a venous circulation and how intimate And related is this hepatic portal system, feeding the gastrointestinal, especially the upper gastrointestinal um, system. So, in a nutshell, the liver receives the oxygen and nutrients it needs in blood, comes from two large blood vessels. The portal vein provides about 2/3 of the blood, and this blood contains oxygen and nutrients, obviously brought to the liver from the intestine for processing. The other system is the hepatic artery that provides the remaining 1/3 of blood. This oxygen-rich blood comes from the heart and provides the liver with about 1/2 of its oxygen supply. So receiving blood from two blood vessels helps protect the liver. If one of these blood vessels is damaged, the liver can often continue to function because it's receiving oxygen and nutrients from the other blood supply. So it's sort of like um, a compensatory, system. Um, in Western countries, the most common cause of portal hypertension is increased resistance to blood flow caused by extensive scarring of the liver and cirrhosis, which is most often due to chronic excessive alcohol intake. Portal hypertension leads to the development of new veins, which are called collateral vessels, that directly connect the portal blood vessels to the general circulation, bypassing the liver. Because of this bypass, substances like toxins are normally removed from the blood by the liver can pass into the general circulation. These collateral vessels develop at specific places. The most important are located at the lower end of the esophagus and at the upper part of the stomach. And this is why you will see esophageal varices in these areas. Here, the vessels become engorged and full of twists and turns, very tortuous. And as they become varicose veins of the esophagus or esophageal varices, or in the stomach, gastric varices. These engorged vessels are very fragile and prone to bleeding, sometimes seriously and occasional with fatal results. Other collateral vessels may develop on the abdominal wall and the rectum. Portal hypertension often causes the spleen also to enlarge because of the pressure interferes with blood flow from the spleen into the portal blood vessels. So pressure in the portal blood vessels also may cause protein-containing fluid, that's ascites, um, from the surface of the liver and intestine to leak into the abdominal cavity. So this is what is called ascites. So in some, you see the something that is um, physiologically beneficial for the liver in terms of feeding the liver with two different circulatory system in the presence of cirrhosis, how these collateral circulations can become problematic. Um, this pictured also presents some um, locations for the upper GI bleed, like um, the hiatal hernia, the Mallory's White syndrome, some esophageal varices, the hereditary telangiectasia, and so on. So, diagnostic approach. Where is the bleeding site is the big question, whether it's upper GI versus lower GI. We draw a line at the ligament of Treitz. The ligament of Treitz is the junction of the duodenum and the jejunum. Anything that happens above that ligament of Treitz is considered upper GI bleed. In other words, it's like the boundary, right, for us to determine whether it's upper or lower GI bleed. So anything below the ligament of Treitz or below the junction of the duodenum and the jejunum is considered low gastrointestinal bleed. So we have here upper versus lower ligaments of Treitz, and you will see how this relates to the anatomical components of that sort of like arbitrary decision what is going to be considered upper and lower, but is helpful in aiding the diagnosis of these bleeds. So esophageal varices. Um, Esophageal varices. Here you have an endoscopic view of a large esophageal varix at the gastroesophageal junction. You can see it like sort of like protruding. Think about, a varicose vein, because that's exactly what they are. Um, Sort of like protruding into the lumen of the GI tract, specifically here in the esophagus. So, how we collect some good history to determine that this is an upper GI bleed? Um, it's usual positive use of aspirin of other NSAIDs. Alcohol consumption very closely related to that. Presence of liver disease, um, very, very common, especially in cirrhotic and decompensated cirrhotic patients. Peptic ulcer disease, you'll see also weight loss and dysphagia, reflux, aortic aneurysm is also another cause for the upper GI bleed, as well as the abdominal aortic vascular graft. So all those are elements that you have to take in consideration when taking a history of upper GI bleed. What is a clinical presentation then? Well, you have basically five possible presentations. Number one, hematemesis. Vomiting blood is like a given. Um, then you have a more tricky one, melena, black tarry stools, which are associated with blood loss of 200 milliliters. You need to know this. When patients have melena, when the nurse or you witness melena and you see black tarry stools, that means that this particular patient have lost at least 200 milliliters of blood, okay, in 12 to 24 hours. Um, so it's obviously the transit of that fresh blood through the GI. It may take 12 to 24 hours until it's defecated, makes these stools extremely malodorous, for one, and second, with this consistency of like tarry, very black, dark. Um, Upper GI, again, anything above bleeding above the ligaments of Treitz. So how we know that this melena that we are seeing is is coming from the upper GI? Well, because hematochezia, which is bloody stools, you will see some elements of red blood in the feces. Usually points more to lower GI bleed. And in addition to that, if the patient have been experiencing vomiting, retching, excessive coughing, and even seizing preceding the clinical presentation, you may suspect like a Mallory-Weiss tear or the alcohol abuse or some anorexia, bulimic rituals, and that will sort of point your history to make a diagnosis of upper GI bleed. So again, if you see hematochezia, it's not upper GI bleed, it's lower GI bleed. And hematochezia are it's called also bloody stools and it's very pathognomonic of lower GI bleed. Remember that. So how we evaluate these patients? Well, usually we do gastric lavage to confirm the upper GI bleed. And predictive of a high risk lesion is obtaining bright red blood from that lavage. We have to be careful when inserting this NG tube. Like I said, you can disrupt, esophageal varices if that's the case, and then contribute more to the bleeding in the upper GI tract. The But it's necessary to place an NG tube because two things: it will decrease the risk of aspiration because blood is extremely irritant and causes the vomiting, induces vomiting, and also it will also point us out to detect the presence of bile or non-bloody aspirate, which can be misleading and does not rule out post-pyloric source of bleeding because the pylorus may be closed. So, anytime that you see like a bright red vomit, that's an ominous sign. Okay, it's talking about a high risk lesion. So, anytime that you see a patient with hematemesis, hypertension, tachycardia, and anemia, this is a patient that you don't sit on. You need to refer this patient for a GI consult. Consult your GI immediately, and usually they will do diagnostic endoscopic study or even therapeutic if it's called for. So as far as like lab diagnostic evaluation, clues as to the location, upper versus lower, is important. Um, you will have increase in the BUN creatinine ratio. Increase in the BUN creatinine ratio indicates upper GI source because it points out to a major blood loss and hypovolemia. In patients without renal disease, a BUN greater than 25 milligrams per deciliter usually translate into a loss of a minimum of 1 liter of blood. So very, very good indicator. Also, persistent azotemia for more than 24 hours after the cessation of bleeding. Azotemia is also associated with increase in BUN and creatinine and also points out to hypovolemia. So the clues as to the location of this GI bleed, upper versus lowered, one element that we can be very comfortable about making a diagnostic decision is using the BUN creatinine ratio to rule out or actually rule in upper GI source. So again, the diagnostic evaluation of blood loss, the single most important aspect of care is help with the aggressiveness of volume resuscitation, give blood, give volume to contrast the effects of hypovolemia and just to take care of the complications associated with that hypovolemia and hemorrhagic shock. Um, any other addressing any other indicators derived from clinical data, and remember, every time that we see severe hemorrhage, this is what we categorize severe hemorrhage with a loss of 1 liter of blood or more. um, you have to remember, let me go back to the lab diagnostic evaluation, the BUN creatinine ratio that is increased, anything greater than 25 milligrams per deciliter translate into almost a loss of a minimum of 1 liter of blood. So, how we evaluate this significant blood loss? Well, the patient will present with resting tachycardia, um, usually of greater than 100 beats per minute or 20 beat increase from baseline if the baseline heart rate is greater than 100 beats per minute. Orthostasis, which is pulse increase greater than 20 beats per minute. Systolic blood pressure decrease greater than 20 millimeters of mercury, and also diastolic blood pressure decrease greater than 10 millimeters of mercury. We also going to see hematochezia and also the failure to clear bright red blood from gastric lavage. Um, Remember that persistent azotemia for more than 24 hours is an indication of hypovolemia because volume loss contributes quantitatively more than the digestion of blood in raising BUN. So, and is the sole determinant of azotemia 24 hours after cessation of bleeding. Remember that. Um, we also have to be cognizant that these patients are going to be requiring transfusions, usually more than 1 unit every 8 hours. We're going to be evaluating for lactic acidosis to sort of like get an idea of the perfusion of this patient and azotemia. Um, Azotemia is also a good indicator of the volemic state of the patient. So what are the cardiovascular responses to blood loss? Well, there's many factors that may impair or mask normal responses to blood loss, and that includes drugs, pre-existing dehydration, oxygen desaturation from pulmonary disease, the state of the cardiovascular system, particularly in atherosclerotic cerebrovascular disease, abnormal concentration of plasma proteins, and miscellaneous conditions like spinal cord disease, neuropathy, renal dysfunction, shock, even congesting heart failure. We need to make a decision whether this is acute versus chronic. So, in an acute presentation, you will see tachycardia, the orthostasis that we talk about, peripheral vasoconstriction. This patient that to touch is cold and clammy. Um, you have to consider also acute end organ dysfunction and some insidious but also sometimes very overt mental status changes and oliguria. Oliguria is less than 400 milliliters per day in adults. And this is a common hallmark of acute kidney injury, which points out to what, impairment in the renal function, right? So you will see that BUN creatinine ratio going. In most clinical situations, acute oliguria is reversible and does not result in intrinsic renal failure. Versus chronic. So in chronic response to this blood loss, you will see patients with a little bit more stable hemodynamics and retention of hypotonic fluid. So this is a problem because impairment or masking of normal responses can sort of like increase the prevalence of GI bleed in a chronic fashion. So, what are the diagnostic workup for this? Upper GI endoscopy, absolutely. This will localize and identify the lesion, and also we can do, as I have said before, therapeutic intervention to correct the hemostasis. Upper GI studies with radio contrast are contraindicated because it interferes with subsequent endoscopic evaluation and intervention. So, no radio contrast for these upper GI studies. um, the um, the endoscopy is a diagnostic procedure of choice, and in cases where endoscopy is non-diagnostic and gastric variceal bleeding is suspected, studies such as endoscopic ultrasound or portal venography or CT angio can be used. If we have a high suspicion for gastric and esophageal variceal bleeding. Cirrhotic patients with upper GI bleed should be administered a prophylactic antibiotic, usually a fluoroquinolone, preferably prior to endoscopy. It's simple and safe, and there's some contraindications. Obviously, the uncooperative patient is number one, or suspected perforation. Endoscopy is an excellent method to locate the bleeding site and timing. Um, Timing endoscopy is crucial. You have to make a decision in light of hemodynamic instability. So early endoscopy um, increases cost without a change in outcome for low risk patients. However, if identified as low risk, the patient may be discharged home. So risk is a little bit of subjective issue in making a determination in the timing of endoscopy. In my experience, I have seen endoscopy only done, and again, I work in ICU when there's some hemodynamic instability, and the suspected bleeding cannot be corrected in some instances by medication. Like, for example, in the case of esophageal varices, um, if the blood loss is not um, severe, and the patient is not hemodynamical, unstable, we use propranolol, Indrel, to reduce that portal hypertension, and and then when the patient is a little bit more stable, and after going through CT angio and knowing exactly where are the lesions, then we prepare the patient for an endoscopy study that will have also therapeutic components. And geography, like I mentioned, in the past slide, is very helpful in 75% of the patient. And the diagnosis is made by extravasation of contrast. But again, you have to be careful because of the timing of using angiography and contrast, because it can mask other, bleeding sources once the endoscopy is done. There's a you require a brisk bleeding for geography to be effective, and that's we're talking about a rate of zero point 0.5 to 1 milliliter per minute. 85% of the bleeding originates from the branch of the left gastric artery, so they really look into the circulatory system with a special attention to the left gastric artery. Is Angiography again is used if endoscopy fails, and diagnose recurrent bleeding of unknown origin. It's accurate in 50 to 75% of patients, but it has serious complications. You can see dissection, you can see thrombosis, obviously allergy to contrast, sometimes ischemia and perforation. So it's not a benign study. Um, Also, you can make use of nuclear medicine studies using um, per label RBC scan, which localize very effectively the bleeding and detects even small low flow bleeds like zero point 0.5 milliliter per minute. So it's very sensitive and specific for lower flow bleeds than angiography. So again, we're going to reiterate more about esophageal varices. They need to be evaluated by endoscopy or endoscopic ultrasound or portal venography or CT angiography. Cirrhotic patients with upper GI bleed, you have to administer prophylactic antibiotic prior to the endoscopic procedure, which is usually fluoroquinolone. Look at those engorged veins protruding into the lumen of the esophagus. So, sorry, how we predict outcomes on these patients? Well, we stratify the risk. So we have patient characteristics versus, also relationship to the amount of bleeding. It's usually patients with older age, greater than 60, with severe comorbidities, onset of hemorrhage after hospitalization. And related to the amount of bleeding, we have hematemesis of bright red blood, hematochezia, gastric lavage with bright red blood, hemorrhagic shock, and the requirement of high transfusions volumes. So, what is the endoscopic stigmata of bleeding? Well, clean ulcer base usually have a prevalence of 35% with a lower risk of bleeding, 3 to 5%. Notice that the highest risk of bleeding is an adhering clot, like I said at the beginning of the lecture, 25 to 30%. So sometimes, disrupting that clot is not a very good idea. And also the prevalence of that prevalence is 10%. 10% also prevalence are oozing without visible vessel, which has also a risk of bleeding of 10 to 20%. But the obvious, the 90% risk of bleeding is when you have an active arterial bleeding, and the prevalence of those instances are 10%, followed by also non-bleeding visible vessel with a risk of bleeding of 50% and a prevalence of 25%. So risk stratification may be useful in that it may allow the identification of low-risk patients who can be managed safely without the need for hospitalization. So by stratifying the risk of patients with upper GI bleed can be done by using clinical and lab data and endoscopic findings. Endoscopic risk stratification depends on findings that predict the risk of bleeding. And although several scoring systems based on this finding have been proposed, they have not been validated in large studies, so they're usually not used in routine routinely in most centers. So it still remains physician clinical expertise and more of an anecdotal data to make that a stratification. Prioritizing clinical approach is usually paying attention to the assessment of blood loss and ongoing loss, the resuscitation measures to bring that patient back to normal hemostasis, history and physical, and determining whether there's urgent versus non-urgent diagnostics. So how we approach this assessment. If we evaluate for shock, and shock may occur with blood loss of 40%. So what are the signs of symptoms of shock? The agitation, the pallor, the hypotension, the tachycardia. We can see also bradycardia with severe blood loss. So this requires an ongoing monitoring blood pressure and pulse, and you will see in ICUs these patients are immediately placed an arterial catheter and flow track and follow hemodynamics very closely. So fluid resuscitation is required. So this is a patient that is going to get an ICU admission. You're going to place a large bore NG tube placement, and you're going to be infusing normal saline while you wait for type and cross of matched blood. Oxygen, absolutely. Because of the decreased oxygen carrying capacity of the low flow state, and to prevent metabolic acidosis, and very closely monitoring of vital signs, urine output, CVP, and again, immediate consult with GI and surgery. So you see a patient with hematemesis, hypotension, tachycardia, anemia, all signs and symptoms of shock. They need to be evaluated by GI immediately. So especially if the patient is presenting with bright red vomit, which is an ominous sign and indicates a high risk lesion. You need to remember that. Consult. The large bore IV access or central preferably, and you at least 2 IV lines, but if you have one central line, that is perfect, because you will be able to then use rapid infusers and give large volumes of resuscitation fluid or blood in a short time. So that will assure also hemodynamic stability. The volume resuscitation with crystalloids as you wait for the blood, and then transfusing packed red blood cells. Usually, you will transfuse packed red blood cells in healthy young individuals if the hemoglobin is around 7 grams per deciliter. And elderly patients with comorbidities, anything below 10, I will transfuse. So the goal is to have greater than 7 grams per deciliters in healthy young individuals, and greater than 10 grams per deciliters in elderly with comorbidities. So obviously you need to correct the coagulopathy. That's a priority. And consult GI and surgery if the bleeding is severe, and then you'll send also the usual lab tests: CBC, Crag factors, your PT-PTT, INR, your fibrinogen. You can order a tag, type and cross, obviously, and don't don't follow very closely the initial hematocrit because it poorly reflects blood loss. So basically, go by the hemoglobin, the degree of the anemia. Um, Unfortunately, overuse of transfusion is common during this resuscitation phase. The packed red blood cells are the preferred blood product, and you need to correct coagulopathy. The goal is to maintain platelet count greater than 50,000 cells per microliter. Maintain prothrombin time within 2 seconds of upper level of normal. And after replacement of factors and platelets, you may give recombinant activated factor 7 to correct the severe coagulopathy in hepatic failure. Although I have to say that factor 7 is extremely expensive. It's not available in every institution, and it has some contraindications and some um, negative criticism from in the medical community. So it's not as widely used as it used to be before. Um, if you're gonna be giving massive transfusion, um, more than 3 liters, you should put that blood products and crystalloid products through a warmer to prevent hypothermia. Um, If we decide to also treat this patient pharmacologically, obviously PPI, acid suppressive therapy, is a must. Is adjunct to therapeutic endoscopy for PUD-related upper GI bleeding. High dose of PPI infusion following a bolus injection reduce the rate of rebleeding. And mostly of these patients, especially in the ICU, you will see them on PPI therapy, BID, IV. Lansoprazole or Prevacid, a 90 to 120 milligrams bolus is usually administered, and then 6 to 9 milligrams an hour infusion for 48, 72 hours, and then we switch to twice daily dose. We also use Protonics, pantoprazole, 40 milligrams BID, and then we convert to PO. Um, Again, for the esophageal varices, they carry a high mortality rate, from 21 to 50% in the first episode. Most patients have underlying cirrhosis, which complicates the clinical picture, and you see some predictors of rupture like variceal size, red marks on the varices, severity of liver disease, intravariceal pressured, cutaneous spider angiomata, um, and some others are not correlated with bleeding, like esophagitis, and the degree of portal pressure elevation over 12 millimeters of mercury. Management of variceal hemorrhage is the most rapid type of upper GI bleed. Greater than 90% episodes cause hematocrit to drop less than 30%. 50% resolve without treatment, though. So early endoscopy is a must. These patients You'll see early endoscopy done on them, um, because, well, variceal bleeding subsides spontaneously in only 15% of the patients. So the other 50% needs to be addressed immediately. And because of the mortality is very high, even as high as 70 to 80% in patients with continued variceal bleeding or rebleeding. The It has to be addressed very early, because the greatest risk of rebleeding is within the first 48 to 72 hours, although it can occur as late as 6 weeks. So, um, one important part of this management, especially in the acute phase of that upper GI hemorrhage, is octreotide infusion, and through endoscopy, band ligation or sclerotherapy. They go in and inject alcohol into the varices to basically desiccate the vessel. Very rarely, the use of balloon tamponade is used, because this is a very friable, brittle tissue, and that balloon deployment sometimes causes more bleed. So, endoscopic band ligation involves the application of a small suction chamber to a standard endoscope tip, and allows the varix to be pulled into the stretch band, and then the band um, is released by a trigger device that and that band wraps around the varix base, causing eventually subsequent necrosis and scarring. Um, Also, the balloon tamponade with a Blakemore tube, as I said before. And I don't know if you recall from previous lectures that the problem with this Blakemore tube is the migration of the tube occluding the airway, and also the rupture of more vessel because of the mechanical force against the wall of the esophagus, and some shear and tear. So it used to be frequent, and now this Blakemore tube is used sort of like an emergency situation when you have massive blood bleed and you don't have an interventional radiology or GI on hand in the first few hours. So it's sort of like a temporary thing until you can get your team together and take that patient for ligation and endoscopic procedures. And you also have the TIPS procedure, which is TIPS is the transjugular intrahepatic portosystemic shunt. That's what it's called. And it's a metal expandable stent that is placed angiographically between the branches of the hepatic and portal veins to create a non-surgical shunt between the portal and systemic venous system. So this is an interventional radiology procedure, and obviously the patient has to have some sort of like hemodynamic stability to go to travel and to go into the interventional radiology and have this procedure done. Very effective, especially in patients that are waiting for liver transplant. It's a good measure to sort of like relieve that portal hypertension. Other specific management of UA upper GI bleed is the acid suppression, splanchnic vasoconstrictor for variceal bleeding like octreotide, and vasopressin analogs. The use of antibiotics, fluoroquinolones for variceal bleeding, especially in cirrhotic patients. Upper GI endoscopy, the angiography, and surgery. So this slide basically summarizes the specific management. Octreotide inhibit the secretion of hormones involved in vasodilation, and this property makes octreotide useful in treating variceal bleeding and orthostatic hypotension. The way it works is octreotide increases the splanchnic arterial resistance and decreases the gastrointestinal blood flow. The hepatic vein wedge pressure, the hepatic blood flow, the portal vein pressure, and the intravariceal pressure. This decreased blood flow to the portal vein reduces portal venous pressure in patients with cirrhosis or portal hypertension. And the majority of patients with portal hypertension have a reduction in variceal bleeding when giving octreotide or somatostatin. Uh, Prophylactic antibiotics, like we talk about, is very important. In cirrhotic patients, antibiotics may also reduce the risk of recurrent bleeding in hospitalized patients who bled from esophageal varices. Um, so, patients with cirrhosis who present with upper GI bleeding from varices or other causes should be given these prophylactic antibiotics, preferably before endoscopy. Um, So again, the goal here is to stop the bleeding. Room temperature lavage with gravity drainage um, is usually done to also prevent the irritation and the retching and vomiting of patient. And then the endoscopy with non-thermal injection of sclerosing agents like alcohol, vasoconstrictor, or normal saline. Either using thermal endoscopy procedure that makes use of laser, a heater probe, or direct cauterization. Both methods are effective and is basically uh, a physician preference. Um, this is a slide that depicts an endoscopic therapy for bleeding ulcer. Sorry, we see the ulcer. We see here the injection catheter depicted by in the C. And where the ulcer is, that sort of like yellowish area, and above that your bleeding point. So the endoscope is directed to these areas for treatment. Uh, Surgery sometimes is necessary for peptic ulcer disease related bleeding. The indications for non variceal hemorrhage surgery are life threatening hemorrhage, refractory to pharmacologic and endoscopic intervention, or failure of medical therapy to resolve or prevent the recurrence of peptic ulcer disease, or an ongoing bleeding that cannot be contained. High mortality, as high as like 30%, and these surgeries are not very much preferred by um, either general surgeons or gastric or surgery that is specialized in gastric and abdomen, because not only the mortality can be high, but they have a great number of complications. So, but sometimes is the destination therapy. Um, Also, you have stress-related mucosal damage, which is results from a complication of critical illness. The stress ulcers, and they're a very common cause of GI bleeding in the ICU. These patients presented with acute respiratory failure requiring mechanical ventilation for greater than 48 hours and are coagulopathic. And these two are very strong independent risk factors for stress-related mucosal damage. You also have a splanchnic hypoperfusion, um, uh, pathology critical factor. Um, these patients also show clinically evidence of bleeding that occurs up to 25% who do not receive prophylactic therapy. 5% of them will require transfusion. And all these conditions increase the length of stay in the ICU, the morbidity, mortality, and obviously the cost. Um, Patients, with subepithelial hemorrhage also within 24 hours of admission um, to the ICU present with this stress-related mucosal damage, and this most of this stress-related mucosal damage are asymptomatic and clinical insignificant, but they also can be overestimated, and then you will have a severe complication if that stress-related mucosal damage persists or increases. And this uh, slide just summarize what is the effect of critical illness in the development of stress-related mucosal damage. You'll see all the mechanisms there, specifically um, things that affect the cardiac output, the splanchnic hypoperfusion, and the consequent effects of that reduction in the splanchnic perfusion, and how stress-related mucosal damage finally ensues. And this basically is in very broad but detail way discusses the GI mucosal injuries specifically to the upper gastrointestinal bleed. Um, a section in lower gastrointestinal bleed will follow this lecture. And again, this is part of the gastrointestinal healthcare problems lecture compendium presented by Dr. Christopher Blackwell, the Associate Professor and Program Director for the Adult Gerontology Acute Care Nurse Practitioner Programs. Thank you.